White cataracts has always been a challenge, and specifically the rhexis. Has this rhexis between a manual and a femto been a difference, and has femto helped us to give us a good round regular capsulorrhexis? Now just have a look on this patient. A good viscoelastic has already been coated. We are trying to initiate this capsulorrhexis, but I feel the positive intralenticular pressure, this rhexis might give way. So I again re-inject a very good cohesive viscoelastic. I try my forceps, I start rolling in, I aim for a very small size, but look, the destiny has something different. Now this rhexis, if you see here, tends to move out. I try to keep it within the limits, but no, the rhexis is extended and it's at the 12 o'clock position. The rhexis has given way. I use my capsulorrhexis scissors and then try, but my tag is still left over. So I failed to achieve a continuous capsulorrhexis. All throughout this phacoemulsification procedure, I doubt whether the rhexis might give way and I might encounter a drop. So I have to be very careful with my parameters. I don't apply a positive posterior pressure so as to avoid any break in the posterior capsule. But look, something else is there, and this rhexis is extended posteriorly and there is a large break and a small dialysis. My 3-piece might help me out, but I plan after an anterior vitrectomy to put this IUL in the sulcus. Though with this I might achieve a good centration of this 3-piece IUL, but in any case, if I would have been planning a premium lens like a toric or a multifocal lens, I still believe I need a better solution. I need a better solution for these white in high intralenticular pressure cataracts where I can achieve a good rhexis, because I believe a good rhexis is the first and the foremost to address these premium patients. So this is the patient after being subjected to the lens X. Now look, I have achieved a round capsulorrhexis. I open the side ports and the main ports, but the most critical steps I believe in this is the capsulorrhexis, and as you see here, just a dimple down technique and my capsulorrhexis can easily be separated. So now I am quite confident. I might separate these pieces. I might gently do a good hydrodissection and I can deliver this nucleus, eat it up and carefully put in whatever the premium IOL I might think of. Though the inside core of the nucleus doesn't appear so dense, it's a young cataract. Note carefully the rhexis. It's a round, regular 5.5 rhexis. And compare the same 3-piece in a round rhexis and in the back. Here we use a grid pattern and just see the capsulorrhexis. Viscoelastic is being put in and the central capsule is already separated. Just gently dimple down and the capsule can be pulled up easily. hydrodissection. And with this grid pattern, hardly any phacoemulsification energy is required and the lens can easily be sucked in. A thorough irrigation aspiration. Just see the size, the shape and the centration of the capsular opening, and that is what makes these tools an ideal for premium patients, specifically those patients which have a high intralenticular pressure and there are very high chances of Australian flag in these patients.